Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is Primary, Urgent, and Emergent Care, What's the Difference? And is sponsored by Jefferson's Ferry. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is Dr. Adam Wass, Medical Director of Mather Hospital's Emergency Department. Dr. Wass received his medical degree from Stony Brook University and completed his internship at Scripps Mercy Hospital in California. He then completed his residency in emergency medicine at the University of California, San Diego Medical Center. Prior to joining Mather, Dr. Wass worked as an assistant attending within the Northwell Health System. He joined Mather Hospital's emergency department in 2009 and has been the medical director since 2014. Dr. Wass?
Thank you. Thank you for that nice introduction. Good afternoon. So thanks for joining today. Welcome to the HealthyU webinar. I'm excited to talk about one of the subjects that is near and dear to myself and all of my colleagues, and that is when we scratch our heads and we wonder why patients come to the emergency department with a specific thing that we think may not be appropriate for the emergency department. So I compiled a list of things that I think would be good for the community to know. What is appropriate for primary care, what is appropriate for urgent care, and when do you really need to come to the emergency department? So if you could advance the slide, please.
This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Thank you. Okay. All right. So when do I need to go to the ER, or what's not appropriate for urgent care? Next slide, please. So I would like to talk today about first, what is appropriate for urgent care. They're great for minor injuries and illnesses. And then we're going to get into a head-to-toe list of common ailments that you may encounter at some point during your lifetime. And when should you go to primary or urgent care for this? When should you go to the ED? And when should you call 911? And then we'll finish up with an update on COVID-19, which I'm sure everyone has some questions about. And then we'll get into our Q&A session. So urgent care is so convenient, right? And that's why they've become very popular over the last 7 to 10 years or so. They're great for patients who have insurance. Mostly they only take patients who have insurance. Their big selling point is short wait times. There is an exception now during COVID-19, and I can talk a little bit about that later. But your care at urgent care is going to be rendered by either a physician or usually a physician assistant. And I can tell you, generally, it's more heavily weighted towards physician assistants with either on-site or remote guidance from a physician. And these urgent cares are designed to treat minor medical illnesses and injuries, and they've been very successful. They've had a good business model because their model is we'll get you in and out quickly, and they'll handle anything from insurance physicals to minor injury. And I've even seen people say they get their primary care urgent care with blood pressure medicines as well. So I'm going to disclaimer, I am not an expert in urgent care medicine. I've never actually, I have worked in urgent care, but it was a long time ago. And a lot has happened since then. And I do believe they are trying to expand their scope, but this talk is really geared towards my perspective as an emergency physician and what we think is appropriate for the acuity of certain medical conditions. Next slide, please. So what is urgent care good at treating as far as injuries? Well, if you have a minor laceration that requires a few stitches, that's perfect for urgent care. Primary care physicians are generally not going to be able to manage that, but at urgent care, they are trained in treating minor trauma. First degree burns, even minor second degree burns, like scalds, are perfectly treatable at an urgent care. Ankle injuries, swollen knees and feet, finger sprains, minor nosebleeds, and most neck and back pain. These are very, very common medical ailments. People will sometimes go to primary care for these. The problem with primary care is, sometimes these problems come up urgently and you want to be seen right away and get some relief. And so urgent care is perfect for these common minor ailments. The next slide. And illnesses, right? One of the reasons that I never wanted to go into urgent care medicine was because what I hear from my colleagues who work there is that it's sometimes, and I think they're getting better at this because the standards are changing. They're sort of thought of as an antibiotic factory. People go there when they have an upper respiratory infection, expecting antibiotics, and the doctors and the PAs there will just give them out, even though there's really good science saying that in most cases they're unnecessary. So, and we can talk a little bit about that. But so upper respiratory infections, great for urgent care. These are typically very minor and not going to cause any major problems. Earaches, simple urinary tract infections, insect and tick bites, very good for urgent care. Most rashes, blood pressure problems, and we will get into that a little bit later, are generally okay for urgent care. I know most people get very, very concerned when they have elevated blood pressure levels, but we'll talk a bit about why that is not such a big concern in most cases. And then COVID symptoms, which we'll talk about specifically as well. So we'll start with our head to toe assessment of, starting with the head, obviously, what sort of conditions are appropriate for urgent care and when should you be running to the emergency department. So we'll start with headaches. So what kind of headaches are there? There are, a few different kinds of categories of headaches, right? So there's sinus headaches, generally associated with sinus inflammation, congestion, allergies, or infections. Cluster headaches are typically, they're not so common. They're more common in young males. Typically, it's behind the eye. It's a searing, intense pain, and it's relieved actually with oxygen. Putting nasal cannula oxygen on somebody with a cluster headache has been shown to be helpful, and NSAIDs, but definitely not dangerous. Tension headaches, that's the classic band-like headache around the temples and the forehead. Very common, the most common type of headache. Oftentimes associated with stress because it is muscle tension that's causing that squeezing pain. And then, and definitely not a dangerous headache. And then migraine headaches, which are fairly common, more common in women than in men. Generally tend to be, people in their teens, 20s, and 30s. Typically gets a little better as people get older. Oftentimes associated with nausea and vomiting. And again, can be scary because it can sometimes be associated with some neurologic symptoms, but generally not dangerous and can be managed. Next slide, please. So vast majority of headaches have a benign cause. When is urgent care appropriate? If you have a headache that fits your typical headache pattern, say you get migraines, oftentimes with women it could be after eating a certain food or it could be around the time of their menstrual cycle, and it fits your typical migraine and you don't have any new symptoms, you can go to urgent care for medical relief. If you have a headache that's associated with some sinus symptoms, say you always get allergies, or you have a cold and an upper respiratory infection, you got a lot of sinus pressure, that's not a dangerous headache. That's something you could definitely go to urgent care for. And the caveat is you have to otherwise feel normal. When should you go to the emergency department? Pardon me. If it's a new headache, a headache you've never had before, if it's sudden in onset and very severe, oftentimes you may have heard the expression, it's the worst headache of your life, right? The worst headache of your life is classically taught in medical school as being, you have to rule out a ruptured aneurysm. And I think that's something that lay people are somewhat familiar with. And we do get people coming to the emergency department with these, new onset sudden severe headaches. I would say another reason to come to the emergency department would be if you have migraine headaches, and this happens a lot, and they're so severe that you can't even take medicine, that you're so nauseous and you're throwing up that you can't keep things down. That would be a reason to come to the emergency department, because then you're going to need IV fluid, and you're going to need intravenous medications to make you feel better. And we do that all the time in the emergency department. So that would be another reason. And when should you call 911? Well, if there's a change in mental status, like you become confused, if the headache is associated with a seizure, or if you have stroke-like symptoms associated with a headache, such as a speech deficit or a loss of motor function, facial droop, that would definitely be a reason to call 911, because then we would worry about stroke-like symptoms. And strokes can be either a bleeding stroke, which would be more likely to cause a headache, or what we call an ischemic stroke, which is just typically a clot in a blood vessel that blocks the flow of blood to part of the brain. So the point is, the majority of headaches are benign, but just in those few cases, again, so any concern for stroke, confusion, seizures, any sort of odd atypical things would definitely be something to be seen in the emergency department for. Next slide, thank you. So neurologic symptoms, right? When would urgent care be appropriate? So if you have a typical pattern of a chronic neurologic problem, like say you have spinal stenosis in your back, or you have disc disease and you have tingling down your leg, or you have sciatica, or that you have a pinched nerve, or you're a diabetic and you know that you have neuropathy in your fingers or in your toes, and it's just like a typical pattern that's maybe flaring up, that would be appropriate for either seeing your primary care doctor or going to an urgent care. But really, any new neurologic symptom, anything that you haven't had before, like I said, anything that would suggest a stroke or a seizure would need to go to the emergency department to get checked out. And when to call 911? If you suspect a stroke, the reason that you should call 911 is because we now have, EMS crews who are very well trained in managing patients with stroke. Stony Brook even has a mobile stroke unit that will come to the site of certain calls that sound like strokes. And it's this big ambulance, and it's got a CAT scan machine in the ambulance. And they can actually perform the CAT scan right away if there's a suspected stroke, and give clot busting medication in the ambulance if it looks like it's a stroke that might be amenable to that kind of treatment. So, but what you need to know is this very simple acronym of Be Fast, okay? It's all over the hospital. We have these signs for Be Fast, and it's a basic recognition of when somebody might be having a stroke. So B is for a balance problem. If you have a new onset, I can't walk, I feel off balance, that could be a stroke. If you're having eye problems, basically, not so much eye pain, but a visual disturbance, like, part of my vision just cut out, right? I can't see the right side of my field of vision. That would be concerning for a possible stroke. Obviously, F is for facial droop. If you started to notice that, your face was drooping on one side, your eye was sagging, that would be a concern. A is for arm weakness. Most strokes would be associated with weakness in the upper extremity limbs. So if you notice, I can't, my right arm is not moving, or my left side is not moving as well as it should, my fingers are clumsy, that would be a sign of a possible stroke. And then a speech problem. Speech problems typically are going to be difficulty finding words, right? Or what we call aphasia. So if you're having a new onset where you can't put words together, you can't string a sentence together, that would be concerning for a possible stroke. And then the T in Be Fast is time. So time being that if your symptoms have been going on for less than 24 hours, meaning that they're acute, and also time is of the essence. So you call 911, you get to the hospital. We are a primary stroke center. Most hospitals in the area are either a primary stroke center or a tertiary stroke center, meaning that we can perform an initial evaluation, do a scan, look for signs of a stroke. And then if it's appropriate, we can give you clot busting medication. And it's time is of the essence, because you need to be aware that if you're having a stroke, there's a very narrow window to give clot busting medication. We're only talking about between 4.5 hours at the most. And the clot busting medication is most effective when it's given soon. So if you have any inkling that you or a loved one is having a stroke, you have to get to the hospital right away, immediately. Because the problem is people wait, and then it's several hours later, and then they fall out of that window, and then we can't give the clot busting medication and give people that benefit. So I want everybody on this call to know, any signs of a stroke, get to the hospital right away. Just call 911. All right, next slide, please. So here you go. So here's the be fast. So again, balance, eye problems, facial droop, arm weakness, speech difficulty, and time, right, is of the essence. Next slide, please. All right, so since we're still in the headspace, we're going to talk about behavioral health issues. Now, Mather has an outstanding psychiatric inpatient unit, both adult and adolescent, and we do get referrals from all the way out as far as the Hamptons, and I've seen people come from Nassau County and even Queens to come here for our behavioral health unit, which is just, like I said, outstanding. You know, with the onset of the COVID pandemic, I think a lot of underlying behavioral health problems have been uncovered. I think we are, as a society, becoming less stigmatized in discussing behavioral health issues, and I think that's a good thing. I think it's important, and being able to recognize it in yourself, recognize it in somebody else, will allow you to get yourself or to get them some help. And so, you know, there is, of course, a broad spectrum of different behavioral health issues. We'll just talk about a few things here, and when, you know, when your level of alarm should be raised. So things like anxiety, which is extremely common, right? And maybe insomnia, without any, you know, thoughts of suicide or harming anybody. Those are something you should really see your primary care provider about. You know, I don't know how much urgent care is going to do for you. Most physicians who practice unscheduled care do not feel comfortable prescribing medication for, like, a tranquilizer, right, to help you sleep, or medication to help you relax, because those are habit-forming medications. And really the best treatment for anxiety and, you know, minor depression symptoms is therapy and maybe antidepressant medication. And those are things that some primary care providers are comfortable doing, and certainly behavioral health specialists, but generally not within the bailiwick of urgent care or emergency medicine. So when should you go to the emergency department with a behavioral health issue? Well, if you or a loved one are experiencing suicidal thoughts that are serious, if you're having a plan for any kind of self-harm, that's serious. That's something that we take very seriously here, and we always get a psychiatrist to see those patients and evaluate those patients for any serious risk of self-harm. Any thoughts of homicide, you know, wanting to, you know, seriously, you know, injure somebody else or kill them. And then hallucinations or delusions. Hallucinations, you know, most people think of, you know, visual hallucinations, seeing things that aren't there. Pardon me, but in actuality, in the behavioral health realm, most people who have severe like psychotic depression can get auditory hallucinations, where they sort of hear things, sometimes like little echoes that can sound like voices. Those would be concerning. And then delusions are beliefs that are apparent to everyone else that are not true. Like if you know, are convinced that, you know, there are aliens in your basement, that would be an example of a delusion. And that's a sign of psychosis, which is a more severe mental health issue. And that would be something to seek urgent treatment for in the emergency department. Like I said, we're very fortunate at Mather to have an incredible behavioral health team that helps us when we have patients brought in with these issues. And then when to call 911. If things escalate, if you have someone who has behavioral health issues at home, then things like violent or threatening behavior, anything that involves, you know, the use of a weapon, 911 needs to be called, because number one, you might need to get police involved for physical protection, and then two, you know, they'll get EMS involved, and they'll make sure that the patient is brought to a place where they're safe and they can be seen by a behavioral health specialist. And then any suicidal gesture. So if someone has taken pills, if someone has cut themselves, if someone has, tried to poison themselves with carbon monoxide, or run an automobile, or a bicycle or something into an object deliberately, obviously they need to go to the ER by 911 because they could be injured, they could have internal organ damage, and they need to be evaluated. So I'll be happy to take questions at the end about this, but I thought this was an important topic because I think behavioral health is becoming more of a national issue, and I'm glad that it's out in the open now. Next slide, please. So sticking around the head area, so next would be the eye. When is urgent care appropriate? So most minor eye problems are fine for urgent care. I know that they do carry slit lamp tables there so they can have a close look at the eye. Generally at urgent care, they're not going to be able to dilate your pupil and look at your retina like the eye doctor does, but anything on the superficial surface of the eye usually is within their realm. So pink eye, very, very common, right? Also known as conjunctivitis, can be diagnosed and treated at urgent care. Minor eye injuries, as long as there's no vision changes. And what I'm alluding to there is like a corneal abrasion, like if you're mowing the lawn and something flies at your eye and then you have a pain and maybe a little bit of blurry vision, that's often a corneal abrasion. That can be managed at urgent care without a problem. If you have swelling of the eyelid, like your eyelid becomes, red and swollen, and maybe there's like a little bit of crust at the where your eyelashes are, that's a condition called Blepharitis, and that can be managed at urgent care too. When should you go to the emergency department? If you have an eye injury that results in severe pain or a change in vision, or if there's blood around your eyeball itself, that should be seen by emergency. If you have severe eye pain without trauma, pardon me, that could be something serious. So severe eye pain around your orbit area without any trauma could be glaucoma. It could be a blood clot or an infection inside your sinuses. So that's something that would need to be evaluated. If you have a visual disturbance like lights or floaters or a dark shade that's occluding part of your vision, that's something that really should go to the emergency department. And then any swelling or redness around the eye that's painful, that could be an infection, like what we call a periorbital cellulitis, and that needs to be evaluated in the ED as well. When would you call 911? Well, really, again, if you have complete or even partial sudden vision loss, you may want to take an ambulance ride to get to the ED right away. And I say 911 just because that needs to be dealt with right away. That could be a retinal detachment, which really needs to be seen by an ophthalmologist very urgently, because they can do a surgery to correct the defect, but it has to be done within hours. And any visual disturbance that's associated with stroke-like symptoms, so headache, dizziness, speech or motor deficits, that's associated with a visual disturbance, would have to be, get to the ED right away. So 911 would be appropriate. So, I guess the best way to think of this is mostly outer eye problems, could probably be seen by urgent care, but the deeper you go, right, pain inside the eye, bleeding inside the eye, visual disturbances that could be coming from the retina. So anything that's, involved in the deeper parts of the eye really should be seen in the emergency department. Next slide, please. Nosebleeds. So this is something we see every week in the ED, and they're very common. They're going to get to be more common soon as the weather gets colder. And the reason is when we turn on our heat in the house, what happens? The air gets warm and very dry, right? Because in the wintertime, the relative humidity level goes down outside, right? So you're dealing with a low relative humidity level to start with. And now you have dry heat in the house. So the air gets very warm, very dry. What happens is that dries out the mucosa inside your nose, and that makes it sort of, it can crack, right? Once, like dry skin can crack. So the mucosa inside your nose, if it gets really dry, can crack, and that can cause bleeding. Now, most nosebleeds are going to stop on their own, right? However, when should you be concerned about a nosebleed? So if you have a nosebleed that stops when you put pressure, and now if you feel your nose, right, there's the hard part of your nose up here. That's where your nasal bone is. And then just below that is where the cartilage starts. And that's where I tell people that's where you pinch when you have a nosebleed, is you pinch right below the hard part and you totally clamp down your nose like that. And you can see how it is doing to my voice. That will stop almost all bleeding. All right. I tell my patients to hold it for 20 minutes. And in most cases, the majority of cases, that will stop any nosebleed. If the bleeding keeps recurring, however, meaning that it stops, but then it comes back, you're going to need to be seen in the emergency department if you can't get into the ear, nose, and throat specialist right away, which most people, generally can't get a same-day appointment with ear, nose, and throat. If the bleeding doesn't stop, even with pressure, come over to the ED. And then the other things to be concerned about is if you get a nosebleed and you're taking an anticoagulant medication like Plavix or Coumadin or Xarelto or Eliquis, right? Because what happens? These medicines are designed to prevent blood clots from forming. So when you're bleeding, your body's natural response is to make clots. But if you're on these medications, you can't. So it's very difficult to clot. And so there's a good chance you're going to need either medication inside the nose and some sort of tamponade, right? Something to put in there to physically put pressure on the blood vessels and make them stop bleeding. So again, any sort of blood clotting medication, anticoagulant medication with a nosebleed really should be seen right away. When should you call 911? Well, if the bleeding is so bad that it makes you faint, or if the bleeding is going down the back of your throat and causing a possible airway obstruction because it keeps running down the back of your throat, that would be called a posterior nosebleed. Those can be dangerous. Really, if you're having issues, call 911, get to the hospital right away. Next slide, please. All right, ear issues. Not super common, generally very minor. Most of them can be dealt with in urgent care. Most earaches, most sinus infections. When should you go to the ED? If you have hearing loss, oftentimes that can be associated with an external ear infection. So there's 3 different types of ear infections. There's inner ear infections, and that's what we call labyrinthitis, which can cause vertigo. Then there's middle ear infections. That's what kids get all the time, right? Is behind the eardrum, the fluid behind the eardrum. And that, again, that's what we treat with usually oral antibiotics. That can definitely be seen by primary care or urgent care. And then there's external ear infection. So that's an infection of the ear canal or the outer edge of the ear here. And it can actually, these external ear infections can extend even to the whole surrounding ear and the skin around the ear. Generally they're treatable with topical antibiotic drops. So minor ones can definitely be seen in urgent care, but if there's significant drainage coming in, you might have to have what's called a wick placed in there, meaning we take this little teeny piece of firm, it almost looks like styrofoam, like a rectangular shape, and we put it in there, and that allows the antibiotic drops to go deep into the canal and be effective. So I would say most cases of ear issues can be dealt with at primary care or urgent care level, but if you have something like severe looking red inflamed ear, like with a fever, go to the ER. If you have a laceration that is on your ear, the ear, as you probably know, it has underlying cartilage that gives it its shape. And a lot of lacerations to the ear will penetrate to the cartilage. And if it's a pretty big wound, oftentimes we'll call a plastic surgeon in to manage that, because one, for cosmetics, because ear injuries can cause a hematoma, which is a blood collection. And if you look at this, ear right here, the upper part of the ear, how many of you ever seen like a boxer with what they call cauliflower ear, right? That happens when they get a shot to the ear and it bleeds inside and it forms like a bubble. And if that's not drained properly, that bubble will never go away and you'll have a permanent ear deformity. So that's something that definitely needs to be looked at right away. Oftentimes when this happens and I see a patient with that, I have to make a small incision and drain out that blood. And then I have to pack and put a pressure dressing on the ear to keep that blood from reforming and keep that ear nice and thin so it retains its shape and you don't get that cauliflower ear. So that's another reason to go to the emergency department. And then when would you call 911 with an ear issue? Really, if you have like a sudden hearing loss, that's the only scenario I can imagine where you might need to want to call 911. But like I said, most ear issues can be dealt with, at the urgent care level. But I would say significant ear injuries or redness infections around the ear, you should come to the ER and get checked out, because we might need to consult ENT or plastics in those cases. All right, mouth issues. That looks wonderful, doesn't that? So that is actually an example of a strep throat right there. So what is appropriate for urgent care as far as mouth issues? So most tooth problems, in a pinch, right? If you can't get into the dentist, you have what feels like a tooth infection or a tooth abscess. What you're really going to need in that scenario is probably something for pain and an antibiotic as a temporizing measure until you can get to the dentist. Most mouth sores, like a canker sore, perfect for urgent care. That's not a big deal, not an emergency. Most sore throats, pain in the TMJ is temporomandibular joints. That can be dealt with at urgent care. Lacerations that involve like the red part of the lip only, or the inside part of the lip, they can generally deal with those at urgent care as well. When should you go to the ER? If you have lip or tongue swelling that comes out of nowhere, oftentimes people who take certain blood pressure medicines called ACE inhibitors, this can happen. You can get swelling of the lip or tongue. That needs to go to urgent care because you can obstruct your airway. Okay, that needs to go to ER. I'm sorry. If you have a tooth infection that is causing swelling of your face, meaning that it's like an abscess that's coming out, you should have that looked at in the ER because that might need to be drained. And then if you have a laceration of your lip that crosses the red mark, you can't really see because of my mustache, but if it crosses the red area of your lip and goes into the skin, you should really go to the ER for that, because you might need a plastic surgeon in that case, because when you repair the lip, right, if the cut goes through the lip like this, it could look like this, right? The lip could look off like that. So you're going to need to carefully align the lip back into its normal position so that it heals and the red border is contiguous and you don't have like a little step off, okay, if you're not careful. So that's why we always say a laceration that crosses the lip should be seen in the emergency department. Oftentimes, if it's minor, we'll deal with it. If it looks like it's significant, we'll call a plastic surgeon in to deal with that, because you want to have your lip healing, where the red surface is nice and contiguous. When should you call 911 for a mouth issue? Well, if you're having difficulty speaking or swallowing your own saliva because the back of your throat is so inflamed, or you feel like your tongue is very swollen, or if you have uncontrolled bleeding within your mouth, those would be reasons. And those are mainly airway issues, right? We don't want anyone to ever get into a situation where, their tongue is so swollen or the back of their throat is so swollen that it obstructs their airway. That's a nightmare for an emergency department physician, because then we have to think about intubating. We have to think about, if we can't intubate a patient because there's an obstruction there, we might even have to go through the neck to get an airway and save your life. So anything that could potentially be obstructing your airway and causing you difficulty breathing, you have to get to the hospital immediately. Next slide, please. All right, upper respiratory infections. Let's talk about upper respiratory infections. The vast majority of upper respiratory infections, and this includes sinus infections, do not require antibiotics. I'm going to say that again. Upper respiratory infections do not require antibiotics. So when is urgent care appropriate? Almost all the time. Okay, if you have upper respiratory infection symptoms such as runny nose or congestion, sore throat, and cough, it's almost always viral. You can go to urgent care. They can give you symptomatic relief. The main thing that we have to rule out is a bacterial infection such as strep throat, which we just saw on the other slide, or a middle ear infection. So strep is a bacteria, which needs a antibacterial antibiotic, and middle ear infections are usually bacterial as well, and they need antibiotics. Everything else, including sinus infections, does not require antibiotics. Now, I'll say for your education, what qualifies as a significant sinus infection? Okay, because most sinus infections are colds, okay? But a real sinus infection is someone who has yellow, thick stuff coming out of their nose for at least 7 days, not improving, and associated with a real fever, like at least a 101 fever. If you have all those things, then maybe you have a bacterial sinus infection and you need antibiotics. But if it's within 7 days, you're not running a real fever, and what's coming out of here is mostly clear, you don't need antibiotics, okay? Antibiotics, why not just throw antibiotics at everybody? What's the bad thing about antibiotics? There's a lot of bad things about antibiotics. Side effects, right? They can cause nausea, they can cause stomach upset, they can cause diarrhea, they can cause C. diff diarrhea. I don't know if you know what C. diff diarrhea is, but it's a very bad bacteria in your colon that can cause serious diarrhea and can even be deadly. What else is bad about antibiotics? If we keep using antibiotics in people, then these smart bacteria over time are going to become resistant to them. And then our antibiotics aren't going to be good for anything. So please don't beg your doctor for antibiotics if they don't think it's appropriate, because we don't want all these bacteria becoming resistant to antibiotics. And then what are we going to have when you have a real infection, right? All right, so for an upper respiratory, when should you go to the ER? Really, again, so if you have anything in your throat that you think is causing difficulty swallowing or difficulty breathing, that's a reason to get to the hospital right away. If you're very short of breath, sometimes people who have chronic asthma or emphysema, if they get an upper respiratory infection, that can cause a lot of wheezing, and they might need to go to the hospital right away as well. All right, but most healthy people with your average garden variety upper respiratory infection, really just symptomatic treatment is all that's necessary. Okay, next slide, please. Thank you. Neck pain. Most neck pain is caused by muscular strain, okay? When to go to urgent care? I mean, you can mostly manage neck pain at home. If it's not responding to anti-inflammatory medicine or, warm compresses or heat pads, you can go to urgent care and maybe they'll give you a muscle relaxer. When should you go to the ER? Well, if your neck pain is caused by a trauma, right, such as a motor vehicle accident or a fall, then you're probably going to need imaging. And nowadays we're turning to CAT scans because they're way more sensitive than X-rays, which we used to use back in the day. So, and we are often surprised with like a fall from standing, especially in someone who's, over the age of 70, 75 or so. Even with a relatively minor injury, you can get fractures in your neck. So we take neck pain very seriously in the setting of trauma. If there's anything that suggests tingling or numbness in an extremity, especially your upper extremity, associated with neck pain and especially weakness, that can mean a pinched nerve or a bulging disc that's pushing on the nerve and causing nerve problems in your arm or your hand. That would be serious and concerning, and we might need to get an MRI in that case and have a look, because you might need either pain management or even surgery if you have a bulging disc that's causing problems with your arm or your hand. Other neck sort of issues, if you have a food impaction, you're swallowing, this oftentimes happens with meat, and it gets stuck in there and you can't swallow anything, saliva, water, you have to go to the hospital, because you'll probably need to have a gastroenterologist put a scope in and get that food bolus out. And then with neck pain, when should you call 911? If it's associated with chest pain, oftentimes neck pain can be referred pain from a heart attack. It can refer to the neck or the jaw. Anything that would be concerning for that, or anything that would be associated with stroke-like symptoms. Oftentimes people with strokes complain of neck pain. So that would be a reason to get to the hospital. Again, like we mentioned before, with a stroke, you got to get to the hospital as soon as possible. But, again, most neck problems are, most of them come from muscle tightness, muscle spasm, and they respond to conservative treatment, and urgent care is appropriate for most of them. All right, next slide, please. All right, so chest pain, right? What can cause chest pain? Well, there's a lot of very simple and common things like heartburn, but there's other things that are more concerning, right? Angina means ischemia, meaning not enough blood flow to the heart. That's causing the heart muscle to die. That's not a good thing. Pericarditis, that's an inflammation around the heart. That's usually benign, but it can be a little bit scary. And then MVP doesn't mean most valuable player. It's mitral valve prolapse, which is just a specific movement of one of the valves in your heart that can cause a sensation that is often perceived as pain. Um, and then the other common things that cause chest pain are chest wall pain, like an inflammation of the chest wall, lung problems, bronchitis, pneumonia, and then even like peptic ulcer disease, problems with the stomach, because your stomach is so close to your diaphragm, can sound like chest pain. So let's look a little further. Next slide, please. So when is urgent care appropriate for somebody with chest pain, right? You wouldn't think you should go to urgent care with chest pain, and in most cases you should not. But if you know that it's from a minor chest trauma, right? Like you walked into something and you injured your ribs, or you fell and you hurt your ribs, and that's what's causing your chest pain and you know it, you could probably go to urgent care and get checked out if you're not, feeling too serious. If your pain is associated with coughing, and you know that it's from coughing, like you cough real hard and that made your chest hurt, then that's probably okay to get checked out by urgent care. Or if you have a history of GERD, right, gastroesophageal reflux disease, and this pain fits your typical pattern of GERD, feels like your usual GERD, and you just need some sort of antacid relief, you ran out of your Protonics or whatnot, then that's probably okay to go to urgent care. For anything else, though, you should go to the emergency department. Any kind of new or different chest pain, any pain that comes on with exertion, anything that's associated with shortness of breath or dizziness or sweats or nausea, any chest pain that radiates to your jaw, your neck, or your arm, right? That is concerning for something potentially serious, right? Like a myocardial infarction or a heart attack or something else, and you need to be evaluated by a doctor in an emergency department. When should you call 911? If you faint with an episode of chest pain, you really should get to the hospital right away. And if you have a history of heart disease and you have chest pain, and say you take nitroglycerin and it's not making it any better, you better call 911. So I think chest pain is kind of a no-brainer. That's definitely, in most cases, an ER visit. I think most people know that. I know a lot of people do call their doctor and say, hey, I have chest pain, and the doctor's office is always going to tell you, just go to the ER, because they know that there are a lot of potentially bad things that cause chest pain, and they want to make sure that we do our job in the ED and rule them out. So, like, again, a few things, mainly if you know it's chest, coming from the chest wall, you could go to urgent care to get checked out, but almost pretty much everything else has to come to the ER. Next slide, please. All right, blood pressure problems. So we talked about this before. When is urgent care appropriate? Any sort of elevated blood pressure without symptoms. So if you're in the pharmacy and you take your blood pressure, or you're at home and you're on a home blood pressure machine and you take your blood pressure and it's high, it's say 175, right, over 95. And that's concerning to you, but you don't have any symptoms. You feel fine, right? Except for the anxiety of knowing that you just took your blood pressure and it's high. First, you really should, if you have a primary care doctor, which some people don't nowadays, you should call your primary care doctor. And if you have no symptoms and your primary care doctor can get you in, they're really the number one place you should go for blood pressure issues, because they're the ones that are going to be following your blood pressure. They're the ones that are going to be prescribing your blood pressure medication and making any changes to your blood pressure medication, because that's not going to happen at urgent care, and that's not going to happen in the emergency department. If you come to the ER with a blood pressure of 175 over 95 and you have no symptoms, I'm going to say, how are you feeling? Okay, you're fine. Okay, maybe we'll do some blood tests or something just to kind of check out your kidney function and stuff. But most of the time I'm going to say, go home and follow up with your primary care doctor and try to relax. Don't take your blood pressure medicine. Don't take your blood pressure that often, because you're just going to freak yourself out. When should you go to the ER with blood pressure issues? Well, if it's consistently over 180 over 120, that's what we call a hypertensive urgency. And that really should be brought down urgently. Not an emergency. We're not going to be, throwing an IV in you and pumping IV medicine to bring your blood pressure down for 180 over 120. But we do want to see that blood pressure come down over a certain period of time. What mainly concerns me as an emergency physician with high blood pressure is if that high blood pressure is causing problems to your organs acutely. And by organs, the number one, right? Brain and heart. So if you're having high blood pressure that affects your heart, it can precipitate a heart attack. So you can have chest pain, shortness of breath. And if you have severe headache or stroke-like symptoms, those are the things that concern me. That would tell me that I need to bring your blood pressure down right now, okay? So when to call 911? If you have any stroke-like symptoms, we talked about those before, the be fast, right? That would be a reason to call 911. But I want everyone here to understand, elevated blood pressure, if you check your blood pressure and it's high, I usually recommend that you don't check it again for at least an hour, because if you check it again, it's just going to be higher and it's just going to send your anxiety levels up. You're going to go running to the ER. I'm going to do a very cursory exam on you, tell you that you're fine, and have you follow up with your primary care doctor, because those are the ones who really should be managing your blood pressure. All right, so I hope that makes sense. And I'll be happy to answer any questions about that at the end. All right, we should move along though, as it is getting late. Back pain, very common. Okay, next slide, please. Most back pain episodes are muscular strain, just like with the neck. If it's not relieved with anti-inflammatory medicine, rest, and warm compresses, you can go to urgent care. That might give you a muscle relaxer. If it radiates to an extremity, but you don't have any weakness, they can check you out as well. When should you go to the ER? Basically, if you have loss of function. If you notice that your leg is extremely tingly or feels weak, like you're kind of dragging it because of the pain that's coming from your back, you have to get seen in the ER. You might have a severe disc problem, pushing on a nerve, and you might need surgery. All right. When else is back pain concerning? If it's associated with a fever, right? It could mean you have a urinary tract infection. It could mean you have some sort of intra-abdominal infection. Sometimes it could even mean that you have pneumonia, or in certain cases, it could mean that you have like an infection of your bones or your discs in your spine. So back pain associated with fever, always a red flag, go to the hospital. All right. And then when does back pain have to call 911? If you get this severe sudden onset of pain, that you should go to the hospital, because that's associated with weakness. That could be what we call like a aortic dissection, which is a vascular emergency. And then if you're so weak from the pain that you can't even get out of bed, you should probably get to the hospital sooner than later, because there's a good chance that you're going to be admitted to the hospital and have pain management, have an MRI, and have a close look at your back and see what kind of problems are going on there. All right, next slide. Upper extremity injuries, okay? Urgent care can manage a lot of upper extremity injuries, most lacerations, as long as there's no tendon or bone showing, and as long as your limb still has normal function. When should you go to the ER? Basically, if you lose function, right? So if you cut the back of your hand, as you can see here, and like, oh, I can't extend my finger, right? That's loss of function. Go to the ER, because you might need a hand surgeon to do a tendon repair, okay? Or if you see bone, all right, that's a reason to go to the ER. If you have an upper extremity injury that is resulting in uncontrolled bleeding, if you lose a digit, God forbid, or have a degloving injury, which is basically where this, it's some sort of machine accident where the entire skin comes off a digit, you have to get to the hospital right away. And also, if you have what you know as a compound fracture, which we call an open fracture, meaning that the force of the fracture is so much that the bone comes through the skin. Sounds gross, I'm sorry, but very severe. Those always need to go to the operating room, call 911, get to the hospital. Next slide, please. All right, abdominal pain. This is a huge topic. I could give a lecture just on abdominal pain alone, okay? These are just to show you what all the different organs are that could be causing abdominal pain. Next slide, please. So when can you go to the urgent care for GI symptoms? Well, if you have typical IBS, irritable bowel syndrome, if you know you have gastritis or premenstrual cramps, and this fits your typical pattern, that's fine. Go to primary care or go to urgent care. If you have diarrhea, right, that without fever and no bleeding, most cases, and if it's bothering you and you're not super dehydrated, you can go to urgent care. Constipation, believe it or not, we see people who come to the emergency room for constipation. As long as there's no abdominal pain involved or vomiting, go to primary care or go to urgent care. They can treat your constipation. If you have rectal bleeding and you think it's a hemorrhoid, like you have a history of hemorrhoids, or somebody looked there and saw a hemorrhoid, in most cases, that's going to be fine. Urgent care can look at that. Hemorrhoids are not dangerous. When should you go to the ER? Well, any new significant abdominal pain that doesn't resolve spontaneously, doesn't go away, you should get checked out. Any abdominal pain that's associated with a fever should come to the ER. Abdominal pain with vomiting, where you can't keep anything down, you have to come to the ER. You're going to need an IV, right? You're going to need to be hydrated. If you see bowel movements, stools that are bloody or black, that could mean internal bleeding, go to the hospital. Also, if you're vomiting something that looks like blood or coffee grounds, that could also be blood, go to the hospital. And then when should you call 911? Well, if you have a severe sudden onset of pain in the abdomen, Again, that could be what we call like an aortic dissection. It could be a ruptured aneurysm in your abdomen, and especially if it's associated with fainting, like a severe sudden onset of abdominal pain with fainting, call 911, right? That could be something really, really significant going on. All right, again, GI is its own separate lecture, but that's just to give you a sort of flavor for what is appropriate for urgent versus emergent care. Next slide. GU symptoms, so simple bladder infections, yeast infections, fine for urgent care. When should you go to the ER? If you're seeing blood in the urine and you're on blood thinners, right? If you have urinary tract infection symptoms with a fever, scrotal pain, new onset scrotal pain, testicular pain, should go to the ER. If you have vaginal bleeding with a positive pregnancy test, you have to go and rule out an ectopic pregnancy. You have to go to the ER. If you suspect that you have a sexually transmitted infection and you can't get to the GYN, you should go to the ER. If you have pain in your side, in your flank, and you suspect you have a kidney stone, you should go to the emergency department. Any penile erection that lasts for more than 4 hours, right? That could be a condition called priapism. That's actually an emergency, needs to be seen by the ER. And then, and again, not to be graphic, but a fractured penis, which happens during intercourse. If that happened, and I don't think I need to be more descriptive as to what that actually is, that's a surgical emergency. You have to come to the emergency department, okay? When should you call 911? Cases of rape, 911 needs to be involved because the police need to be involved. There needs to be an investigation. And then if you have a GU emergency that's associated with fever, confusion, weakness, right, where you might be septic. A lot of elderly people get urinary tract infections that make them septic. That would be a reason to come to the emergency department. Next slide, please. All right, we're gonna have to breeze through the next few because we are short on time. Lower extremity injuries. Most ankle and foot injuries are fine, can go to urgent care. Even knee injuries are okay. And again, lacerations that don't show tendon or bone. If you suspect a hip injury, you have to go to the ER. We have to get an X-ray and then possibly even a CAT scan to rule out a hip fracture if a hip injury is suspected. Hips are a big deal because they require surgery. When should you call 911? If you're unable to bear weight from a lower extremity injury, if you have any kind of uncontrolled bleeding, loss of a digit again, or a fracture where the bone is coming through the skin, again, that would be a reason to come to the emergency room. Next slide, please. All right, swollen and painful joints. Oftentimes this is caused by osteoarthritis. If it's a single joint and you're otherwise feeling well, you can go to primary care, go see a rheumatologist, you can go to urgent care. If you have a swollen joint, though, that's associated with a fever, right? That could be like a septic joint. You have to come to the hospital. If you can't bear weight or move the joint at all, again, we have to evaluate that in the hospital. And if you've had a recent surgery or an infection or a compromised immune system, and now you have a swollen joint, that again could be very concerning, especially if it's associated with like a high fever, confusion, right? The sepsis type picture. You have to come to the ER and get evaluated. Rashes. So most rashes, itchy ones, right? That falls under like contact dermatitis or eczema. Fine for primary care, fine for urgent care. You should go to the ER if you have hives, especially if it's associated with facial swelling or wheezing, right? If you have a red hot painful rash that looks like an infection, you should go get checked in the ED. Or an abscess, right? Abscess would be a pus pocket that would need to be drained. If you have a rash that doesn't blanch when you push on it, okay, and we'll show that in one of the slides, that could mean that you have low platelets. And that would be something that would be concerning. And I'll show you that in the next slide. And then any rash that's associated with throat swelling, again, airway problems, right? Or if you have severe sloughing over a large area that looks like a burn, you can actually get dehydrated and sick from a very large rash that sloughs off, or desquamates as we call it. And you might need IV fluids, believe it or not. We treat that like a burn. That would be a reason to come to the hospital. Next slide, please. So here you have on the left side, that right leg there, which is the one at the bottom, that big red rash. I bet if you felt that, it would feel hot. That's an infection. That's a bacterial infection. Sometimes requires intravenous antibiotics. That's called cellulitis. And then on the right, you have these small little rash papules that don't turn white when you push on them. That's usually a sign of low platelets. And that could be a big problem. You might need a platelet transfusion. So that would be a concerning thing as well. Next slide. Insect bites. Believe it or not, people come to the emergency room with embedded ticks, saying that they need to have the tick pulled out. Urgent care can do that. All right. Happy to send it. So most tick bites, insect bites can go to primary care, can go to urgent care. A common misnomer, people think that if they have a tick bite, that they should get tested for Lyme disease right away. And I'm here to tell you that if you come in with an acute tick bite, right, I'm not going to test you for Lyme disease. Why? Because it takes at least 2 weeks for you to form antibodies that we can detect in your bloodstream after the exposure. So it's useless to get Lyme disease testing immediately after a tick bite. All right, so I want everybody to understand that. Redness and swelling after a bee sting, people come to the ER for that, and they think it's an infection. You don't get infections from bee stings. It causes a histamine reaction that causes swelling and pain, and it usually just does fine with anti-inflammatory medicine and cold compresses, okay? When should you go to the ER? If you have an allergic reaction to a bee sting or an insect sting, right? Where your face starts to swell up, your lips swell, your tongue swells, your throat feels swollen, you get hives all over. Go to the ER, you're probably gonna need an adrenaline shot. All right, and call 911 if your throat is swelling or you're having wheezing. Next slide, please. Oh, we're really pushing up. So here's the Lyme rash, right? Erythema migrans, it's called. So most people know the bullseye rash, which is on the bottom, but it can really present in many different ways, right? It can be all red, it could be bluish red, you could have a blister in the middle. So just so everybody knows, the Lyme rash can look very different than the bullseye. Next slide, please. Burns. All right, we'll whiz through burns. Basically, first and second degree burns, not a big deal. You can manage those at urgent care. Anything that's a 3rd degree burn or 4th degree burn needs to come to the ER. If any burn that's over a large area or involving your face, your hand, your feet, or your genitals really needs to be looked at in the emergency department. You might actually need to go to a burn unit because those burns can become severe. Burns, especially of the fingers, if it goes around the entire finger, can cause so much swelling that it can choke off the blood supply to your finger. And that can be really, really concerning, or even your whole extremity. So face, hands, feet, genitals, all right, any significant burns to those areas need to come to the hospital. Also, anything associated with smoke inhalation, right? Smoke inhalation can cause injuries to your airway. It can cause carbon monoxide problems, and even cyanide poisoning in the unfortunate setting. So smoke inhalation with burns, hospital. Next slide. COVID. All right, quick COVID update. When is urgent care appropriate? Most cases of COVID, right? You know the symptoms of COVID by now. When should you go to the ER? If you're short of breath, if you have a home oximeter, pulse oximeter that's 92% or less, or if you're unable to keep down fluids or you're super weak, right, and dehydrated, because then you're going to need IV fluids. Call 911 if you have the septic type picture, right? Severe weakness, confusion, high fevers, feeling faint, or severe respiratory distress. All right, next slide. All right, how do we treat COVID-19 in this day and age? So now we have monoclonal antibodies. I think we talked about this last time I did the HealthyU. We still have the monoclonal antibodies. We're using a different one now called the Regeneron product. These are for outpatients only, so not if you get hospitalized. They've been shown to decrease hospitalization by 70%, and they're available at a lot of hospital emergency departments or dedicated tent sites like Northwell has at Huntington and at South Shore University. For hospitalized patients, we have remdesivir, we have tocilizumab, and we have dexamethasone, which are antiviral medications, and monoclonal antibody, and dexamethasone is a steroid, and they've all been shown to help inpatients with COVID. But you'll never need that unless you get hospitalized, and God forbid. Next slide, please. Okay, on the horizon, you probably have looked at the newspaper and seen Merck, the big drug company, is coming out with molnupiravir. It's still investigational. It's been shown to reduce death or hospitalization by 50%. And then it's not out yet. And then a word about ivermectin. I know we're at the end here. Ivermectin is not approved by the FDA or the CDC to treat or prevent COVID infections. There have been 21 cases just in August of ivermectin toxicity. 6 of them were hospitalized and 4 were put in the ICU. So people are doing dumb things with ivermectin. It is not recommended currently. There are clinical trials going on to establish whether it's effective to treat COVID. But I would say until we have evidence, please do not go to the the veterinary place and get ivermectin or ask your doctor to prescribe it. It has not been shown to be useful. Next slide. All right, that is it. I apologize. This took a little bit longer than I thought it would. I don't know if we have time for question and answers, but I'd be happy to take any questions.
Thank you, Dr. Was, for your extremely informative presentation. This has been a tremendous wealth of valuable information. If anyone has any questions, I see a few in the queue. Please enter them in the Q&A feature on the bottom of your screen. All questions are anonymous to protect your privacy. First question, I couldn't breathe, so I called 911. I was sent to a hospital by ambulance. I sat in emergency for 3 hours, had blockage in my heart, and they put a stent in. What should I have done? 3 hours waiting, unbelievable.
Okay. Well, I don't know the exact circumstance of what, your EKG looked like and, so basically when someone comes into the hospital with difficulty breathing, we're going to get an EKG. And that's going to tell us right away if it's what we call an ST elevation heart attack, which is like the most severe heart attack. If we see that right away, then we activate the cardiac cath lab, and the interventional cardiologist will come down and they'll take you up there and they'll put the stent in. If it's not that severe finding on the EKG, then what we do is we order blood tests. We get cardiac enzymes, and typically those take an hour or two to get back. And then if we see that they're elevated and we're concerned with the EKG plus the enzymes, then you might also need to go in and have a stent put in. So again, it depends on the circumstance. You did the right thing. You can't breathe. You call the ambulance. You did the right thing. I don't know the circumstance and why there was a 3-hour wait during that period. I would imagine that you did not have the most severe form of a heart attack. And then I guess they took you for a stent. And I don't know if the stent was done here. We've had the cath lab here since May, or if you were transferred. I'm not sure when that happened, but you did the right thing.
When inbound with a patient that is suicidal, not to get the patient more upset, how can we inform without saying suicidal? Mental health with assistance if needed.
Yeah, so I guess, I don't know if you're one of our EMS crews. If you are, thank you so much. I would say if you're coming in and you're letting the ED know, you can just say, behavioral health emergency. That would be appropriate. That would key us up to know that we're going to need to get our behavioral health team involved. And then that's usually all the information that we're going to need when you're calling somebody in.
For nose bleeding, can you take aspirin?
Can you take aspirin like as a therapy for? So I guess I would say if you're on current aspirin therapy and you have a nosebleed, I would probably tell the patient, unless they were like really aspirin dependent, to hold their aspirin for a couple of days. Aspirin is a platelet inhibitor. Platelets are the little cells that clump together to help you form clots. So aspirin is definitely not a treatment for nosebleeds by any stretch. If you're taking aspirin and you get nosebleeds, I usually will recommend holding the aspirin for at least a couple of days. Give your body a chance to form give your platelets a chance to clump together and form some clots, so that clot will remain stable and you won't rebleed.
It looks like there's no further questions. I want to thank you again, Dr. Was, for your time. This has been a wonderful presentation with a lot of great information. Folks, when you exit the webinar, you'll be prompted to take a brief survey. Your feedback is very important to us. Thank you so much for participating in our HealthyU.
My pleasure. Thanks everybody for listening.